Yeah, so the idea that specific vaccination is a kind of an evolutionary driver, really. Whereas if you've got natural immunity, you're going to produce an immune response, whether it's through T cells or antibodies to, oh, I don't know, at least 20 different proteins, 20 different epitopes from the virus. You get
Yeah,
this
that's right. Yeah.
polyclonal response. So the high numbers of antibodies in the community that were cited, people like the Office for National Statistics, were well up into the sort of high 90s of percents. Is that credible given the accumulation of repeated infections that people were, or the virus that people were exposed to, or is there something that's slightly inconsistent with those very high levels of antibodies?
So there's something about it that I just don't quite buy. So I think they were doing a really good measure through Wuhan Alpha and Delta wave. If and you look at the number of people who were said to, like, they were looking at blood donors but extrapolating to the population. And if you say, well, if that proportion of the population have now had COVID, it actually tallied very well with the number of symptomatic people who had tested positive. So you've got a measure, if you've got two measures of the same thing and they're coming out the same, that's pretty compelling. And it was also, similar fraction to the proportion who were susceptible in the household. So everything was aligned, it was all making sense. But then with Omicron, they all fall apart and they're not aligned anymore. And one thing that sort of came out during the course of the Delta wave was evidence from the Moderna trial. It was just one study where they showed that people who had been vaccinated and then had an infection didn't produce N antibodies, these sort of post-infection antibodies, at the same rate as the unvaccinated. It was sort of half, or less than half. So that would mean that you could have the same number of infections in a vaccinated community, but with an antibody test, it would look like there'd only been half those number of infections. And I just wonder if the public health people decided to fiddle with their testing and say, well, we've got to account for this. Let's have a much, much lower threshold of how much antibody needs to be there for us to say it's real. Because it was around that time that it all seemed to go a bit haywire. And when the sort of one other way I've had a sort of finger in the air, is this correct, is just to ask people. So I've done, polls on Twitter and just said, have you had it? It's a very, are you vaccinated? Aren't you vaccinated? Have you had it? Just simple questions. And I've done that more than once over time, and it's very consistent, and it changes over time in a predictable fashion. But the answers to those surveys fit with 10% at a time, not with everybody's had it, now it's over. And it's clearly not over. At the moment, Finland has got a higher hospitalisation rate than they've ever had. Right, so, it's coming back. It's going to surge in December here, like it does every year. It's not over because it hasn't worked its way through the population. And if you speak to people, you'll know people who haven't had it yet, because not everybody has. Quite a few people have had it multiple times, but there's still plenty of people who haven't had it yet. And there seems to be a pattern that the older you are, the less likely you are to have had it. And I think that makes perfect sense, because our immune systems educate themselves through the course of our lives. Now, of course, there comes a point in life when you're quite close to death, when your immune systems fail and you're going to be more susceptible to everything and anything. But before that happens, when you're still, healthy, then you've got a very educated immune system at 80 compared to at 20 years old. And if you look at the antibody levels across those age groups, throughout the whole period, there's always been, every 10 years older, there were fewer people had developed antibodies. There'd been fewer infections for every 10-year gap. And so you can make an argument about shielding, and you can make an argument about young people having a whale of a time, but you shouldn't be seeing a gap between 20-year-olds and 30-year-olds and 30-year-olds and 40-year-olds. That's because of prior education of the immune system, which means
cross immunity, basically, isn't it?
Exactly. Yeah, exactly. And so it makes sense, but it does mean that the age groups who are susceptible going forward are not necessarily the ones that were at the beginning, as it's working its way through.
Because there's these other coronaviruses that are around. There's other viruses which have got probably similar shaped proteins on the surface. These epitopes. There's going to be cross immunity.
I mean, do you remember that study early on with measles and the MMR immunity? That was a fascinating study where they
tell us, please.
So they looked at, this is like 2020 data, and they'd looked at how sick people had become and who'd got infected, and found that people who had antibodies 2 months were protected. And people who had antibodies to mumps from their MMR vaccine had the best protection of all. And it was really a very effective vaccine. And it was a vaccine that we had tons of safety data on. And yet, having shown how protective it was, they didn't want to do anything with it because we had to have novel products being given to everybody for some reason. So, that was just ridiculous because it was such a clear-cut improvement in protection. And that just goes to show also that there's this sort of belief some people seem to have that our immune systems have got a clipboard with the tick boxes for each disease you've had. You've had that one, had that one. And it's not like that. What happens is the pathogen's chopped up into multitude of tiny, tiny fragments. And all your body is doing is saying, that's not me. That is foreign, that bit there. But that bit there being foreign is just simply the shape it's in. And the shape of a tiny fragment of mumps can look very similar to the shape of a tiny fragment of the SARS-CoV-2.
Yeah, we have this idea that, I talk to my students that immunity is specific. You make a specific immune response against a specific organism. But that's simplistic because, as you say, organisms are not, the immune system doesn't say, oh, well, that's the virus, that's the measles, that's the mumps, that's the rubella. It's actually looking at the molecules on the surface of that, the subcomponents of that.
And so I suppose the counter is that if you have had, if you didn't have protection from the other things you've seen previously, then you have an infection, and then you were able to demonstrate that you've had the full immune response to the whole thing, and you can say, yes, you've had that infection. We can show it in your immune response. So I guess it's a bit of both. On the one hand, you don't need to have seen that exact thing before to have some protection, but on the other hand, having seen that thing, you can measure it using things in the immune system.
And yet we were told this is a novel virus. To this, we have no immunity. We have no resistance. This is something completely new. Yeah. Which, looking back, is just ludicrous.
Yeah, and I think would be ludicrous actually for any pathogen, because because your body recognises it as foreign, not recognises it because it's seen it before.
Yeah, but all life on the planet is basically the same. There's the same genetic code, the same amino acids making up proteins. And that there is similarity between the shapes. I mean, we go back to Edward Jenner, who inoculated this poor boy James Phipps with cowpox. And I don't want to go into that story now in detail. I know we've got views on that, but the idea is the cowpox gave cross immunity to the smallpox. It's a different but similar.
Yeah, I think that's a useful concept to explain that situation.
Yeah. I was looking at you with some anxiety there because I know that's a separate topic. So I want to finish shortly, Claire, because we've done so much. But can you just clarify that the measles, mumps, rubella vaccine, was that providing protection against COVID?
Yeah, it was. It was.
So it's the mumps component of it, we believe.
Yeah, and maybe it only did it for the Wuhan wave. Nobody seemed to have looked at it subsequently, but during the Wuhan wave, people who had mumps antibodies had very, very good protection. But there's all sorts of aspects to when we were talking about that sort of 10% a susceptible story. I think there are lots of different ways in which we're protected from infection, and we don't know which one of them is failing. So we're talking about antibodies as if that was the issue, but it may not have been that. So, for example, our respiratory tracts are lined with a mucus layer. In fact, it's layers of different types of mucus that they're lined by. And so if you are next to someone who's infected, or you've breathed it through the air, you've got a huge dose of virus in your air in your lung, that doesn't mean that you are going to be infected. Because if your mucus layer does its job properly, the virus cannot get into a cell. It just can't do that. So something else has to go wrong to allow the virus to penetrate, because that very last layer of mucus that sits right next to the cell is so thick that a single virus is too big to get through it. And the layers that are sort of more runny and above that layer are constantly being swept away up, and then we swallow it and it lands in the acid and it can't cause an infection. So something goes wrong with that mucus layer in some people, and we don't understand what it is. And if we could understand that, then that might teach us all sorts of other things around how the virus spreads and what you could do about it. So there's one interesting theory around how the virus can get through the mucus layer, which is that it hitchhikes on the back of a bacteria. And that's very, very interesting, because going back to Charles Chapin's time, they believed that influenza was spread by a bacteria called nowadays Haemophilus influenzae, which was not the cause of influenza, but they could find it in people who had influenza. Not every time, but they could find it, as if there was a relationship there between those organisms. And you see that, with influenza subsequently, that a lot of the problem with viral influenza is actually the bacteria that are hanging around at the same time, and you get these secondary bacterial infections, and that's why antibiotics have, been so important. And that's also why we have to be very concerned about how viral infection was treated during the course of 2020 onwards, because in the past, if you were sick in the community, you would see your doctor and they would greet you warmly with a smile, and then they would say, well, have a listen to your chest, you sound like you've got pneumonia, I'm going to give you antibiotics. I don't know what's caused your pneumonia, but this is the protocol, you get antibiotics. And the antibiotics these people have been given would have prevented these secondary bacterial infections, but they also had antiviral and anti-inflammatory properties, which would have benefited these people. And then on top of all of that, you've got the psychological benefit of being looked after and not being terrified. When people are terrified, their cortisol levels go up and everything goes south. So instead, we terrified people, told them, well, if you really must come to hospital, wait till you're blue in the face and then we might look after you. And so, of course, all of that response is going to have had an impact on mortality from respiratory disease in that period, because we weren't treating it normally. There were reasons why we gave antibiotics for community pneumonia, even though some of those are viral in the past too.
It's just the antithesis of everything I've learnt and taught over the past 45 years in clinical work and educational work. This is exactly how we don't treat patients. Mm. Every first year student, look, listen, feel, tap. It's how you examine a patient. And if you can't, can you look on the phone? Maybe. You certainly can't listen. You certainly can't feel. You can't palpate, and you can't percuss them. The fundamental basics of any medical examination become impossible.
I agree, and that there's something about when you're in the room with the patient, face to face with them, you get a feel for how they're breathing, how they're holding themselves, how concerned they are, and that's not all from the words they're using. And the idea that they can give you that over a phone call, when the distance from a phone call creates a barrier that you don't have the trust there. It's not just the barrier in communication, the trust barrier gets broken as well. And so people don't get to share in the same way information that the doctor needs to know.
Yeah, when I retired from full-time education and went back to being a junior staff nurse on A&E, it was great. There was no emails and no meetings. But, by that time, I got a lifetime of experience. And some patients, you go into the cubicle and you think, I'm not happy with them at all. Might not quite know why.
Yeah.
And I would go to the consultant and say, I'm not happy with Mr. Smith there. And the consultants, to be fair, said, well, tell you what, John, they might not have said this, but this is what happened. If you're not happy, I'm not happy. And they would go and look at them.
Yeah.
And 9 times out of 10, there would be an unrecognised pneumonia, an unrecognised sepsis developing, and an unrecognised stroke. There was something that you just get from your patient. And the idea that you just sweep all that aside.
Yeah,
it reduces medicine to an artificial intelligence, not a human interaction.
Exactly that. I mean, that is the path that we've been travelling down more and more rapidly. But prior to COVID, as well as recently, is this idea that doctors' decision making is algorithmic and protocol driven. And once you're there, you don't need doctors anymore. So doctors are doing themselves out of a job by pretending that these interpersonal skills, that the trust, and that these signals, this pattern recognition, this the kind of thing that you can't quite put words to feed into an algorithm, don't count for anything, and they do. And moreover, the doctors have a very, very important role as being ethical and being able to look at the patient in front of them at the time and be an advocate for that patient's needs at that time, which will not necessarily fit with any algorithm or protocol, because everybody's unique, and people need to be treated as unique, because otherwise they just get mashed through a machine.
And as well as that, you mentioned that this immense placebo effect, which we must never underestimate, that when you're with your doctor who you trust, just the way they put the stethoscope on your chest, it just gives that confidence. You can feel their competence. I often used to be the patient for things like trauma courses, and the sometimes you get junior doctors holding your head, when I was pretending to be the patient. And one day there was a consultant orthopedic surgeon doing the teaching, and the way he held my head, I could just tell this guy was a superb clinician, just the way he was touching me. And it was you think, oh, this is fine, I'm in good hands here.
Literally.
Yeah, literally. But the massive, and the doctor will just look at you and oh yes, that looks all right. And if it's someone you trust, that the massive positive placebo effect from that. And of course, what we got through the pandemic was a massive nocebo effect as well.
Yeah, well, the doctors are frightened of seeing you.
Yeah.
How well am I if they won't even see me because I'm so deadly sick?
Therefore, I'm probably going to die.
Yeah.
And that can become this idea that you believe you will makes you will, and it's true.
Yeah.
It's true.
We also had the additional problem of people treating people as numbers. And, everybody got very obsessed with the pulse oximeters on the end of the finger, which I think have a role to play, and I think have been actually very important in hospital care. But we've never actually tried using them in the community for chest infections to know what normal looks like. We don't know what normal looks like. And we started to say, well, if it's dipping to 85 or below 90, you need to come in. And I'm not sure that that's right. I'm not sure that that's right. It might have been. But we don't have that control group to say, actually, when people have chest infections and when they're having coughing fits, it will dip and it will come back up. And as long as it's coming back up, you don't need to be in hospital.
Yeah, so we slavishly follow British Thoracic Society guidelines on that. And they need to be, well, basically all this stuff needs to go through the mind of a clinician, doesn't it? But you're right, we need to collect data on this and work out what is normal.
Yeah.
Because very often we don't know the difference between physiology and pathology. Sometimes the line is blurred.
And we had that sort of expression of, well, they've got happy hypoxia. Do you remember that term?
Yeah.
And you think, well, if they're that happy, why are you treating the hypoxia? And they'll say, well, because they might crash at any time, it's all going to be a disaster, and this is what this illness looked like. So it's not like any other pneumonia you've ever seen before. Then maybe they were right. But I think there's a room for a little bit of doubt there that was the best way to go about things. Because once you've told somebody that thing on your finger tells you that you're dying and you need to come into hospital, then you are sort of setting them up for failure a bit.
Yep, you're setting up for the nocebo effect potentially.
Yeah.
So I'm going to wrap this up shortly, Claire, but this mumps, at the start of the pandemic, there could have been massive efficacy in isolating the mumps component of the MMR, giving that to people, and that would have generated significant levels of protection as far as we understand against COVID. Am I overstating the case?
I don't think you're overstating the case, and I think that definitely looked like a promising route to have tried as a vaccine in a situation where we had evidence of that vaccine from before.
Yeah, and of course, the mumps vaccine, we're giving a precise known dose of antigen. We're not giving an RNA instruction. We're not giving an adenovirus vector instruction. We are actually giving the antigen in a totally controlled, precise measure, so we know exactly what we're getting. We give the right dose of the right drug to the right patient, to the right route at the right time. And it's a pity that wasn't perhaps considered more.
Yeah, I mean, I think there's always been this thing where government seems to like to throw its money behind innovation. They can say, well, we're doing something new, and it means that not only are we solving a problem, but we're also potentially investing in a way that could solve other problems in the future. And I think that there are occasions when that thinking is just ridiculous and detrimental, because there are times when actually it pays to stick with what we know. And This was exactly what happened in the swine flu pandemic back in 2009, where the decision was that we needed a vaccine and that the vaccine could not be a conventional influenza vaccine grown in eggs. It had to be something novel. And it turned out that the conventional influenza vaccine grown in eggs was ready at exactly the same time as these novel things. So the claim was it would take too long, but it was ready at the same time. But they went with something novel, and the consequence was, about 100 teenagers in this country got narcolepsy, which meant the sleep centers of their brain were permanently damaged and they could fall asleep or go into a sleep-like paralysis while conscious at any time for the rest of their lives. So hugely disabling. And it probably didn't actually have any benefit for swine flu either. The Swedish public health official, I can't remember exactly what her role was, but she reckoned that it saved 6 lives in Sweden as a max. How ridiculous. You've caused all this harm and you didn't really make a difference.
The arrogance of not learning from that mistake is just stunning.
Indeed. Yeah.
And I like the saying, if it ain't bust, don't fix it.
Yeah. Yeah.
Claire, we have more to do. If you would like to, the next questions would be, which we're not going to do now, but COVID would likely kill me, ? Death certificates are never on, ? A new variant spells doom, ? If you test positive, you have COVID.
Yeah, there's a lot to say on that. ?
1 in 3 people with COVID spread it while asymptomatic? ? Lockdowns save lives? ? Lockdowns are not harmful? ? Masks reduce transmission. I think we've already given a spoiler on that one, but children are resilient and zero COVID is achievable. So that's still to come. In the meantime, do get this. You won't be able to put it down. It's just make sense of everything. And as indeed as this discussion helped massively, Claire. So thank you so much. We've been going for 1 hour and 23 minutes, so you've done very well. And if you'd like to come back to discuss those future questions, we will be absolutely delighted.
Absolutely,
but for now,
I'd love to. Thanks, John.
For now, Dr. Claire Craig, pathologist, doctor, researcher, author, and campaigner for the good of humanity, thank you very much.
Thank you, John.